my camera off and I'm going to introduce you first in Spanish and after that in English, okay?
Thank you.
Bueno, nuevamente les doy la bienvenida a todos los que están dentro de nuestra sala de Zoom. Les voy a presentar a la doctora Stover. Ella es médico veterinario y PhD de la Universidad de Davis, California. También es diplomada del Colegio Americano de Cirujanos Veterinarios. Y sus principales áreas de investigación han sido la biomecánica, la prevención y tratamiento de las lesiones musculoesqueléticas en equinos deportistas, contribuyendo en la búsqueda de factores en el entrenamiento y su adaptación en el desarrollo de lesiones en caballos de carrera. Por lo tanto, le damos la bienvenida y espero que todos disfruten mucho de esta charla. Y ahora voy a proceder a realizar su presentación en español, en inglés. Dr. Stover earned her veterinary degree at Washington State University and her PhD at the University of California, Davis. She's a diplomate of the American College of Veterinary Surgeons. Her major research focuses are the biomechanics and prevention of musculoskeletal injuries in the equine athlete and treatment of orthopedic disorders in domestic and non-domestic animals. Her key contributions to the safety and welfare of horses include discovery and detection of lesions that predispose to catastrophic injuries in racehorses, and elucidation of factors that contribute to injury development in sport horses. Current research efforts are focused on understanding how training and injury affect bone adaptation, or propensity for bone fracture and the effect of arena surface material and shoes on hoof and fetlock, biomechanics, and thus propensity for injury in athletes. So now, Dr. Stover, the microphone is all yours.
Oh, thank you for the kind introduction. It's a real pleasure to be here, and I hope this finds you and your families safe and doing well under the circumstances. So I'd like to share what we've learned about conditions that predispose to catastrophic or unrecoverable skeletal injuries in racehorses. In parts of the world, catastrophic musculoskeletal injuries occur approximately 1 to 2 times for every 1,000 starts that horses make. So consequently, if you have 10 horses in a race and 10 races in a day, you'll have 1 to 2 fatalities over a 10-day period of racing. So it's certainly an equine welfare issue, as well as an issue for jockeys that happen to be injured when these horses fall to the track. But it's also an economic issue for the racing industry. So what I'd like to share with you today is, I think, good news, and that is that over 85 to 90% of catastrophic injuries are associated with pre-existing injuries, either stress fractures of long bones and flat bones, or stress remodeling in subchondral bone of joints. And to me, that's actually good news, because as I hope to share with you today, the injuries develop over several weeks to months before the catastrophic injury occurs. And that gives us an opportunity to detect affected horses and intervene to prevent the catastrophic injury. And further, the more we learn about how these injuries develop, we may be able to prevent them altogether. So today I'd like to cover how injuries develop, conditions that we can detect that precede catastrophic injury, and thoughts for detection and injury prevention. So I'd like to share with you a story we've learned by looking at the humerus of horses that have had a catastrophic humeral fracture. The first clue that something was going on other than an overt fracture from severe trauma is that over and over again, the same fracture occurs, a slightly spiraling long oblique fracture from the caudal aspect of the neck of the humerus going distally. And when we see the same fracture configuration occurring again and again, we recognize that it's not just a step in a hole on a racetrack, but some factors that are consistently predisposing to that injury. When we remove the soft tissues from those bones and actually open the fracture fragments up as if you would a book, you can see this particular image. And if we look at the proximal half of this fragment, we can see porous, rough, woven bone on the surface, or periosteal callus. And in this instance, we can see a dark line associated with pre-existing injury. We know that this callus cannot occur at the time of catastrophic injury or fatality. So it tells us that some events were going on in this humerus before the event that led to fracture. So to understand what's happening, we'll take a look at the trabecula coming off of the inner surface of the cortex of this fractured humerus. If you can imagine that the trabecula is the limb of a tree and the cortex is the trunk, and if we were to jump up and down on the limb of the tree, or the trabecula, we would expect it to buckle underneath, and we would expect it to split at the top. And so our bones are undergoing the same loads and the same things that we see in everyday life from repetitive loading. We also know that there's evidence of bony bridging of this crack, which means that these events occurred before the time of catastrophic fracture. So these cracks or damage within the bones are due to the repetitive loads that the racehorse incurs on the limbs simply through the occupation of racing. So over and over again, the limbs get this sustained loading. And if we think about that in terms of an inert object like this stick, I can break it if I'm strong enough with a single bending load. But if I'm not strong enough, I can wiggle it and wiggle it and wiggle it until it incurs some small cracks and ultimately will break. But it breaks at a load that's much smaller than it would take in a single event. And during the course of this process of fatigue, the stick loses stiffness, strength, until it ultimately fails. So here we're looking at a cross-section or transverse section of the humerus of a horse that fractured the opposite humerus, not this one. And what we see in this scanning electron microscopy section, where the soft tissues have been removed, are large holes associated with haversian canals and blood vessels that course through bone. We see the osteocyte lacunae where osteocytes would reside. And in this specimen, we see cracks that have occurred, and they occur in us in everyday life. Any of us that are any animal that's undergoing loading of any sort. But notice that within the cracks, we have a lack of osteocyte lacunae. And that's because the osteocytes derive their blood supply from the canaliculi that extend from the haversian canals, and the source of their nutrients has been disrupted by the cracks. And osteocytes actually control mineralization within the bone, and if they die, they lose their ability to control that, and the lacunae become mineralized. Now, the other things that we see are large resorption bays, and those resorption bays are actually focused on microdamage or cracks within the back of the bay. And so because we're living animals, not only do we sustain damage, but unlike the stick, we have the ability to remove and repair damage. So bones are capable of healing. This process occurs throughout life by removing damaged bone and replacing it with healthy bone. But a key concept to understand is that bone healing takes time. Osteoclasts, the cells that remove bone, can do their work really quickly. They can do it within days. But to replace bone. It takes a long time to do it in a good fashion. I use the analogy that if we bought an old house on a lot and wish to tear it down and build a new house, we can tear it down in a matter of days, but it takes many months to build a new house on that same lot. So it takes days or weeks to remove damaged bone material, but it takes up to 3 months to fill in those spaces. So if the horse has a focus of microdamage, very quickly that area can become osteopenic because osteoclasts quickly remove the damaged bone. The only normal bone on this slide is in the lower left-hand corner. The rest is an area of osteopenia. So if we look at a horse that had a complete fracture of this humerus on the left, it's been reconstructed, we're interested in looking at the contralateral humerus because both forelimbs are doing the same thing during training and racing. We expect to see the findings that are associated with the impending fracture, but without the artifacts of fracture. On this cross section in the left, we see the white cortex, trabecular bone with bone marrow, and we see what appear to be cracks, and we have this fresh, highly vascularized, woven bone, periosteal callus on the surface. If we look at a similar specimen from another horse, and we microradiograph that thin section, we can see that the fracture line is actually just a row of porosities. So these porosities are throughout the cortex. We see a little older periosteal callus, less mineralized because it's newer, and we see thickened trabeculae trying to buttress this underlying weakness. So we know from mechanical tests that during this stage of osteopenia, the ultimate strength of that bone material is markedly lower. And it takes time during the healing process to regain that strength. So if horses continue racing and training on this compromised bone material, they're susceptible to catastrophic fracture. Much like the perforations on a postage stamp are placed there so that the stamp will tear easily in a very predictable manner, you have a focus of damage that ends up in a very predictable, consistent, complete fracture. However, if given time, this area of osteopenia where the damaged bone has been removed can actually be replaced with secondary osteons. So this is a microradiograph showing the darker osteons are more newly formed because they're less mineralized than the surrounding bone matrix. Now that's what happens when a stress fracture such as that we've been describing in the humerus resolves. So here we're looking at lateral radiographs of the shoulder joint. Here's the glenoid, the humeral head, the caudal aspect of the neck of the humerus. This horse, without radiographic abnormalities, has early clinical signs of a stress fracture. 1 month later, we see abundant periosteal callus. It's not smooth or uniform, so we know it's woven bone. And this is the animal's attempt to buttress or strengthen an underlying weakness. But given time to resolve, the bone gets stronger again, but it also stays a little larger so that it's less likely to resustain a stress fracture. So this would be normal adaptation, ideally normal adaptation to the increasing intensity and stresses of race training. We're familiar with that in this transverse section of the cannon bone of a horse that's not yet been in race training. And with race training, the stresses increase on the cannon bone and we get this expansion on the dorsal medial aspect. So that's an adaptation that then allows the horse to sustain higher loads associated with the higher speeds of racing and training without damage. But not only that, these secondary osteons that form with their sequential lamellae serve as to make the bone tougher, because it takes a lot more energy for cracks to go up and down these mountain ranges across the bone material. So not only is the bone larger, but the bone material within the cortex is tougher. So what determines whether a bone successfully adapts, like this cannon bone, with expansion of the cortex, or goes to catastrophic fracture? And basically, it's a competition or a balance between the rate of damage formation associated with training and racing and the rate that repair of this damaged bone material can occur and successful adaptation to increased training. So the rate with which damage can be repaired is time limited, as I've shown. It's like getting a cold. If you have a cold or respiratory disease, you can prolong how long you have it, but you can't really shorten the time it's going to take to resolve. But what we can control is the rate that damage accumulates, because that's related to the repetitive nature of training and galloping. So here I'm just trying to illustrate a balance, and this is some computer simulations, but when the rate of damage accumulation associated with training exceeds the ability to repair, the porosity within the bone skyrockets and makes it susceptible to injury under otherwise normal training and racing circumstances. If we have training and racing at a lower intensity, we do get an intermediary porosity, but it's able to recover. That's important to recognize, just like the stick example, that the greater the load, the fewer cycles of loading it will take to break the stick. Well, the same thing happens in all of our bones. The greater the load magnitude, the fewer the cycles to failure. And so galloping and breezing do more damage per stride than walking or trotting. And that's why it's been useful to use high-speed exercise as an index of horses' risk for getting an injury. So here I want to share with you how we look at exercise histories and training intensity. And these graphs are going to illustrate a horse's training, his exercise history over time. So we see time on the x-axis, and with time, each time the horse does a high speed work or races, we add the distance, the number of furlongs, cumulatively along the graph. So in this instance, where the circles are high speed works, the filled dots are races, we can see that this horse had 5 works and then a race, and each time an event happened, we added the number of furlongs. Now we can actually calculate the exercise intensity by knowing the number of furlongs over the days that they occurred, and in this case, 11 furlongs per month. So we can follow the horse's entire history. We can see periods where the horse was inactive, trained a lot, and where the races occurred. Now, if we look at 2 different horses, one which had a catastrophic injury in red, we notice, and one that did not but continued to train and race, we notice that the slope is steeper for the horse that had a fracture. Not only that, we know that when both horses had higher intensity during training, they had a layup, and a layup sometimes can be a milder injury. So when we looked at many horses over time, we can show that those have a catastrophic injury have accumulated more distance over time than those horses that did not. So let's look at the conditions that precede catastrophic injury in each particular bone. I think that these are largely related to two different scenarios. One is what I call insufficient conditioning or lack of adaptation to the increased loads associated with training and racing. And the second is different in older horses due to overtraining. So the injuries due to insufficient conditioning, and maybe that's a poor term, maybe I should be using insufficient adaptation, occur early in the training program, like that naive cannon bone that was smaller than the well-adapted cannon bone that was larger. The intensity of training increases at a rate faster than that bone can enlarge. So it's usually associated with high increases in training load. So the fractures due to insufficient conditioning usually occur in younger horses, usually when they're just coming into training or following a layup. And typically they occur in the scapula, the humerus, and the tibia. So we can see here that complete scapular fractures occur often during training and not racing. And most of the statistics that we share on the rates of catastrophic injury are given for racing. But equally, many horses sustain a catastrophic fracture during training. Notably, a third or quarter of thoroughbreds and quarter horses were unraced when they had this complete fracture. If we look at the exercise history of two horses, one that was unaffected and another one that was affected with a scapular fracture, notice that the unaffected horse has been in training for a longer period of time. The affected horse that had a scapular fracture has been training relatively short period of time. And if we look at their exercise intensity, notice that the horse that had a scapular fracture came into training a short period ago, but was actually trained twice the distance over the same time period as the unaffected horse. So we look for these fractures in young horses just coming into training. Similarly, most moving to humeral fractures, similarly, most in our jurisdiction, most of these fractures occur during training, few in racing. Many are unraced, but there's also a high risk for injury after return from a layup. It's also notable that these fractures also can occur at a slow gallop. These horses are not even training or racing at high speeds. And that reflects the fact that these horses are training on compromised bone material. So they're not necessarily being abused, but we've compromised the strength of the bone in an area that allows for fracture under otherwise normal training and racing circumstances. Humeral fractures are also notorious for occurring after a layup. Not sure whether the fact that they're laid up, that we lose bone material because the bone doesn't need it. Bone needs stimulus to maintain its size and its strength, its material. And it may be particularly after layups have been of insufficient length when the horse had a severe stress fracture to begin with. So we're particularly look particularly hard at horses that are coming back from a layup because they need time for their bones to readapt to the stresses of training again. Now, we've recently learned that tibial fractures frequently occur in unraced horses, as well as occur during training and in horses after a layup. Injuries due to overtraining occur later in the training program. They're associated with a high intensity training for a long period, really without an opportunity for recovery. So these horses may have adapted their bones earlier for successful racing, but they've just continued to be trained and worked for a long period of time without an opportunity for really the bones to catch up, for damage to be removed on a continual basis. They tend to occur in older horses. The two that I typically think of, at least in our jurisdiction, associated with overtraining include the pelvis and injuries to the fetlock region. Examples of exercise histories of horses that had a proximal sesamoid bone fracture at the back of the fetlock compared to horses that died for other reasons, we can see that they've had a greater number of works, greater number of races, higher intensity of races per year, more races per year, and they've been in training for racing and training for a long period of time without an opportunity for recovery. We can see this when we look at lots of horses here, 120 that had a proximal sesamoid bone fracture, 148 that did not. And in summary, if these horses were compared at the time of fracture for the proximal sesamoid bone fracture, if we look at their previous training and racing history, these horses were trained more intensely by the steeper slope, more furlongs per month leading up to fracture. I think it's important to understand that these injuries develop over time. They culminate in acute catastrophic fracture, but it also relates to other concerns that we might have when these fractures occur. In this graph, we're looking at several exercise histories of racehorses that died from a catastrophic fracture. Those ones in black are those that died of a proximal sesamoid bone fracture. Those in green died of something else. But interestingly enough, these horses were all moved from one racetrack to a new racetrack or another racetrack with a change in race meets. And at that point in time, at the beginning of the race meet of the new meet, these horses had these catastrophic fractures. But what's important to realize here is these horses were set up for fracture at a new racetrack by the events they had before they ever got to that racetrack. So we want to be careful when horses go to a new racetrack to blame necessarily the racetrack on a lot of injuries without looking at what happened to these horses before they ever arrived. Okay, so let's look at conditions that precede catastrophic injury, and so that we're more able to pick them up from physical exams and other methods. So first, looking at the scapula, this bone almost invariably fractures at the distal end of the spine through the neck of the scapula. Has a very characteristic fracture, slightly oblique, transverse, may have a component that goes into the glenoid. The key feature here is we can recognize the site of pre-existing injury by the periosteal callus associated with the fracture line. It's important that we know that the callus, an attempt by the horse to buttress an underlying weakness, is directly associated with the complete fracture. That's how we know that it was associated with it. And here in this blown up view, you can see the porous nature of the callus that's attempting to bridge that underlying weakness. So on this reconstructed computed tomography exam, the more porous bone or more woven bone of the callus is seen here crossing the bridge of the spine. If we look at a transverse image through this scout view of a computed tomography scan of a scapula that fractured, then this is a post-mortem scan, and we look at it transversely at the location of the green line. We can see the body of the scapula. Here the fracture is coursing through it. We can see the contour of the spine, and we can see that area of osteopenia in the tip of the spine that's creating the weakness, allowing this fracture. The scapula is like half of an I-beam that you might see in the roof of a building, which is helps prevent bending. And this bending causes damage in this area. We see the periosteal callus, the horse is attempting to lay down to buttress that underlying weakness. So knowing the typical location of this fracture, the fact that the spine of the scapula is easily palpable, first finding the greater tuberosity of the humerus, then the spine of the scapula. In some of these horses, you can pick this up from a physical examination. We recognize that bone scanning or scintigraphy is the most sensitive technique for picking up an abnormality, especially before there's significant periosteal callus, but there's significant bone resorption and remodeling in an attempt to repair the damage. But we recognize also that ultrasound techniques can be useful. Here we're looking again at the cross-section of the scapular body and the spine. It should have a nice clean contour on ultrasound examination. When we have one that's had a fractured scapula, we're going to expect to see this very unusual, wide and irregular contour associated with that periosteal callus. Now, having said that, it's important to recognize that callus takes some time to form and that the horse can be at risk for fracturing with very little evidence of callus. And so if you have negative findings, it doesn't really mean the horse may not have a stress fracture. But if you see this sort of a contour, you've got good confidence the horse does have a stress fracture. So if we look at the humerus, here we're looking at the caudal aspect of the neck of the humerus from two different horses. The one on the left, we can see fresh, highly vascular, woven bone callus attempting to bridge this fracture. This is an example of a horse that had acute fracture with minimal callus because it had marked resorption of bone that occurred quite quickly. On the right, we see a horse that's been struggling with a stress fracture for some time. And here we have a highly remodeled, irregular, knobby callus. Some of this callus has been remodeled to lamellar bone tissue, but had an acute exacerbation of that stress fracture because we see this woven bone callus on the periphery. So fractures can occur early on or later on in the process of the stress fracture disease. So this is an example of a reconstructed computed tomography scan of a cadaveric humeri that fractured in a racehorse. We reconstructed the fragments and made red the highly porous bone or periosteal callus. So if we take a longitudinal section through the CT scan, where we're looking at the caudal aspect of the neck of the humerus, we can see the callus attempting to buttress the underlying lesion. We have sclerosis or thickening of trabecular bone doing a similar job because they're trying to buttress this underlying weakness. This cortex on the neck of the humerus should be as densely white as the cortex down here. It's hugely modeled by the mass resorption of bone. If we look at it in transverse section, we see the same thing. Periosteal callus, endosteal sclerosis surrounding a marked osteopenic lesion that acts as a stress riser to lead to catastrophic fracture. Now, there are three sites of stress fractures usually associated with a catastrophic fracture. By far, the most common is this caudal proximal site, but they can occur in other locations: medial aspect of the bone, the diaphysis, and craniodistal medially. We know that when trainers and veterinarians know that their horse has a stress fracture, that these horses can be successfully rehabilitated without catastrophic fracture. We compared horses that had a bone scan at a hospital at Santa Anita Racetrack with a positive diagnosis of stress fracture. 166 horses had a diagnosis of a stress fracture with bone scan. None of them had a catastrophic humeral fracture. Of the 32 bones that we had from horses that had a fracture, none of them had a bone scan. And so we know that if we can help trainers, owners understand what the horse has, they can be managed. It's when they don't know what's going on that we end up with a problem. So again, early clinical signs still at risk for fracture may not see any radiographic changes. A month later, we'll see periosteal callus, and ultimately it may resolve. This is why scintigraphy is the most sensitive method, because if we can bone scan horses where you suspect you have a humeral fracture, you may see a region of increased radioactive uptake. Lately, we've been working on techniques for bone scanning the caudal aspect of the neck of the humerus. It's a little bit tricky because you have to push into the muscle to get directly on the caudal aspect. But if you do, we're able to pick up in some horses a discontinuity in that cortical shell. Discontinuity in the cortical shell. Or on ultrasound, you can pick up periosteal callus associated with roughness in this area. So again, if you can positively diagnose a humeral stress fracture using ultrasound, but negative findings don't necessarily mean that the horse does not have one. Carpal bone fractures are associated with the same syndrome that's happening in long bones. So we have the accumulation of damage, creates bone resorption that can be transient. The horse may be able to resolve, but if continued to train and race with this underlying osteopenic weakness, will lead to carpal bone fractures. This process is almost identical to that of stress fractures of long bones. The only exception is that because of the overlying articular cartilage, there's not an opportunity for a periosteal response. So what we see is endosteal sclerosis around an area of hyperemic bone material that's actually associated with, you look at it with microcomputed tomography, an osteopenic lesion that serves as a stress riser for catastrophic fracture. If we look here, post-mortem samples from a horse that had a catastrophic third carpal bone fracture, usually it's our typical third carpal bone slab, but there are other fractures that occur with it. And the opposite limb of the same horse, we see the pre-existing lesion and associated irregularity associated with bone resorption compared to a control bone, which has nice, consistent subchondral bony plate. If we look at the can bone, we have several types of fractures that can occur, again related to the same pathogenesis. So here we have a mid-diaphyseal stress fracture. If we look at the fracture fragments, and if you look at it carefully, you can see fresh woven periosteal bone on a surface that crosses to the surface of another bone fragment. If we turn this bone fragment over, we see an area that looks very similar to that lesion that I showed on the third carpal bone. This focal region of discoloration is associated with the hyperemia on the periphery that's bringing in osteoclasts to create that focal osteopenia. Now, if we look at the dorsal palmar view on the left, but the lateral view on the right of a horse that had a catastrophic fracture, and we compare that with this horse's contralateral bone, we recognize that this horse had bilateral pre-existing stress fractures. You can see this radiolucent incomplete line, And notice that this one is at the same location and the same direction as that fracture through the fracture fragment. So that discoloration was associated with this incomplete fracture line. And the reason for pointing this out is imaging techniques that are readily available, such as radiography, can be useful for detecting these lesions in horses. There's another region that stress fractures occur that lead to catastrophic fracture, and that's just above the condyle. So I call these supracondylar fractures. If we look at, this is the paired bones from one horse that had a catastrophic fracture. We recognize that most stress fractures and stress remodeling occur bilaterally, or to both the left and the right legs, because both legs are doing the same thing during training and racing. If we look at the lateral views on the right side here, we can see that the location of the complete fracture is associated at the same location as a periosteal callus on the contralateral bone. And if we look at radiographs of those same bones, here we see the periosteal callus, the incomplete cortical stress fracture, directly a reflection of the same configuration and the same periosteal callus through the bone that completely fractured. And occasionally we'll have horses that just have a recurrence or an underlying dorsal metacarpal disease or buck shins. And this bone, which is intact, which is the one we often look at to see the changes that preceded the catastrophic fracture, radiographically, we can just see a hint of linear cortical lucencies. But when we section this bone so that we had parallel sections from dorsal to palmar, we see this red discoloration. Here's this sort of linear line underneath this smooth lamellar bone. Actually, you'd think this horse had resolved buck shins. When we look at those radiographically, so these are slab sections, not whole bone radiographs, we can see the intense and marked damage that's occurred within that cortex. And so anytime I see a radiolucent line or evidence of sort of hazy, diffuse radiolucencies within the cortex, I'm concerned about damage that's present and not yet repaired. So here we're looking at a lateral condylar fracture. So the end of the cannon bone of the third metacarpal bone, lateral condylar fracture, often associated with this articular fragment in the condyle. So here you're looking at the reconstructed specimen from a horse that died from a lateral condylar fracture. And we see the missing lateral condylar fragment. If we take that bone and we open up the fragments as if opening a book, we see this area of compacted cancellous bone and osteosclerosis surrounding again this hyperemic area on the palmar aspect of the condyle. When we take a scanning electron microscopy examination of this region, we see that it's just an area of caverns, huge number of porosities that have just been developed because of the removal by osteoclasts on the periphery of this lesion of damaged bone material, which leaves this bone with a weak focus as a stress riser. The analogy I like to use is that this is like the stress riser that's intentionally put on a peanut bag or a snack bag so that we can tear the bag in a very predictable location with a small amount of force. And this lesion on the end of the cannon bone, another area of stress remodeling, can predispose to this catastrophic fracture. Now, of course, not all lateral condylar fractures are catastrophic, but many that we see are catastrophic because the lateral condylar fracture occurs with either a proximal sesamoid bone fracture or a proximal phalangeal fracture. So let's take a little further look at the fetlock and the proximal sesamoid bones within the fetlock. Very commonly, we see a transverse fracture of the medial proximal sesamoid bone, oblique fracture of the lateral, or an avulsion fracture, loss of support to the fetlock. This is due to one of two lesions. The less common lesion we found first on the palmar aspect of the proximal sesamoid bone. Again, notice the osteopenic lesion serves as a stress riser for propagation, initiation and propagation of that complete fracture. So these are paired, bones from the left and the right leg of a horse that had a right proximal sesamoid bone fracture. More recently, we've discovered what we think is a much more common lesion. If we open up the fragments of the medial proximal sesamoid bone fracture, we again see this very typical lesion that occurs again and again. Bone has only so many tools in its toolbox, and one of them is to lay down new bone, compacted cancellous bone, and to remove damaged bone. And we see the discolored lesion associated with, on this microcomputed tomography scan, an area of osteopenia serves as a stress riser for the fracture. If we look at the contralateral limbs bone, we again see this same things happening to both legs, to both bones, but the one with the more severe lesion ends up fracturing first. So unfortunately, both of these lesions are in locations that are difficult to detect clinically. One is under the intrasesamoidean ligament, the other is subchondral, and often the articular cartilage can still be full thickness on the surface, and so it's difficult to find them. They're small enough to cause a critical defect and predispose to fracture, but they're not large enough to easily detect with radiographs, for example, because of the overlying dense bone. Bone scans are a little bit helpful, but they're difficult to differentiate from palmar osteochondral disease. But more recently, with the initiation of PET scans on horses, and PET scans can be viewed as the three-dimensional perspective of bone scintigraphy. Just like a computed tomography scan gives us three-dimensional information, whereas a radiograph gives us two-dimensional information, we can reconstruct the PET scan so that we can actually specifically localize the lesion because of the ability to look at it in 3 dimensions. That allows us to differentiate apical fractures, which we're not happy about, but it's probably not going to cause a fatal injury, with these lesions in specific locations that we're more concerned about and feel the horse needs to be rehabilitated. Pelvic stress fractures occur typically in many areas of the pelvis, but the most common is over the sacroiliac joint. So here we're looking at the wing of the ilium over the sacroiliac joint, and here's this incomplete stress fracture with attempts at repair. A little closer look at it. Periosteal callus, a little fresher specimen, wetter specimen in this case, around an incomplete, unstable fracture. At postmortem exam, we can pick up the periosteal callus associated really with a large part of the pelvis where the area is injured. And fortunately, while we can pick these up often with bone scans, ultrasound examination has proven pretty helpful in picking up these lesions over the sacroiliac joint. Tibial stress fractures occur in a couple of locations. One is proximal lateral underneath the head of the fibula. This horse has bilateral stress fractures. And the second is caudally, either in the mid-diaphysis or a little more distally. This particular bone had both proximal and caudal evidence of stress fractures. Again, when we reconstruct computed tomography scans where the more porous bone is red, we can see that this horse has bilateral, proximal lateral stress fractures, a caudal distal stress fracture. The important thing here is that the one with minimal periosteal callus earlier, but osteopenia, is the one that fractured. The one that didn't fracture was better buttressed by periosteal callus and endosteal bone deposition or sclerosis, but notice the huge area of osteopenia. And similarly, we see that the callus associated, that you might see radiographically, is associated with underlying porosity. Again, it's important to recognize that early on in the stage of stress fracture disease may be when a horse is most susceptible to fracture. And here we see on a bone scan evidence of increased radioactive uptake on the caudal aspect of the tibia. We found that lumbar fractures are also associated with pre-existing lesions. Typically, they occur from caudal dorsal to cranial ventral. At postmortem exam, again, dorsally, looking at the dorsal spines and the transverse processes, there's usually periosteal callus, and in this case, loss of a complete facet. Notice the facets at this joint, we're missing them here. On the ventral aspect, a large callus is popped off, but you can see the sites that the callus was emanating from both sides. We recognize when we looked at these with computed tomography, radiography, and histology, that while this particular horse had a complete fracture on the bottom, what we thought were two control specimens had earlier signs that these vertebrae were getting in trouble. We have sclerosis around the physes. We have periosteal callus trying to bridge the bottom of the vertebral bodies, and an incomplete fracture through the end plate. So these are all changes in horses that did not have a lumbar fracture that lead up to the catastrophic fracture, where here we can see the sclerosis is much more extensive. Now, if you look at the number one horse here, oops, sorry, the number one horse, maybe we'll run that again. We think one of the, notice how the hind legs are locking up. And so we think that horses that tend to lock up in their stifle temporarily, or that trainers that are thinking that this horse is locking up behind, I'm not sure why, maybe one of the clinical signs that indicates that this horse is getting in trouble with vertebral pathology. So I want to leave you with a couple of thoughts of prevention. What can we do to detect these horses? And the first is to recognize times at high risk. For these insufficient adaptation fractures, it's when horses are just coming into training, may occur during training, but also after return from a layup. They may have had a severe fracture that required a longer layup. And if that didn't happen, then they're coming back with a weakened scapula or humerus or tibia. Thinking about the length of the layup should be, really depends on the severity of the injury that's causing the layup. So not as simple as I'm suggesting, but if horses are coming back from a layup, pay attention to them. We recognize that horses that have a catastrophic fracture had some evidence of lameness in the prior 3 months. They weren't necessarily lame immediately before the catastrophic fracture. I'm entirely speculating, but I think horses get lame when they incur the focus of damage. And when the osteoclasts remove this damaged bone, the pain may be relieved before bone is really strengthened. So if they've had lameness within the previous 3 months, we're still watching them for a while. Just changes in demeanor, poor performance, transient lameness. You know, most of these stress fractures and stress remodeling occurring bilaterally. Horses don't necessarily have an overt single limb lameness because they have a problem that's symmetrical. So the horse may have a respiratory disease or a neurologic problem, but any change in demeanor could be a musculoskeletal problem as well. These lesions occur in predictable locations over and over again. Certainly there are exceptions, but because of the predictable nature of most of them, physical exams can be tailored to looking at specific areas of the body and horses of specific ages or training histories. I know that it's hard. If you're looking after individual horses, you have the opportunity to potentially do more with them. For veterinarians that do pre-race exams that don't have a lot of time, I recognize some of these things may not be practical, but we do a fair bit of manipulation. In this particular horse, she's had lameness, reported lameness, not doing particularly well, young horse, early in training. And here we're attempting to extend the elbow and the shoulder a bit. And the point here is that as she moves off, she looks pretty good. We could say, well, maybe she's a little off here or there, but in general, she looks pretty good. If we attempt to do the same thing with the opposite limb, she just won't even let us do that. This is a horse that had a humeral stress fracture in her left front leg. So these horses can be, for the most part, appear fairly sound, but have a significant problem. Utilize radiographs, you know, when you think appropriate. Certainly some of these lesions may be painful to palpation as well for a good physical exam. We're trying to develop more and more techniques that can be used by practicing veterinarians at the stall side, such as examining scapular and humeral stress fractures with ultrasound. And although we haven't tried it yet, I suspect that this technique may be useful for tibial fractures under the proximal lateral aspect, head of the fibula. And I think I forgot to mention that many caudal mid-diaphyseal stress fractures of the tibia are detected and appropriately managed, but most of them that end up in catastrophic injuries are those under the head of the fibula up high. I think they can be difficult to pick up even with radiographs, and so we're hoping that ultrasound may help us there as well. Scintigraphy is usually very useful actually if you have access to it, but it's certainly not a screening tool because of the use of radiopharmaceuticals and the time the horse has to be in isolation. Just putting in a plug for PET scanning. We're certainly excited about it because it's given us the opportunity to localize lesions and differentiate horses that we think are at higher risk versus other horses. And we're looking a fair bit at pre-race exercise screening as a way to pick up in this horse. We're looking at the exercise intensity variables and particularly out of range from control horses. So we're going to look at them with increased scrutiny. So I want to thank you for your attention today. I hope this has been helpful. A lot of the things I presented were the result of research funding from a variety of sources, particularly the Grace and Jockey Research Foundation. And many horses and students and staff and jockeys, trainers that have assisted in these studies over time. So with that, I want to thank you. I'm honored to be invited to share our research with you, and I hope I've given you some information that is useful in your practices.
Thank you so much, Dr. Stover. That was an awesome talk for us. Thank you so much.
You're very welcome. I hope, yeah, I just hope it was helpful. Thank you.
I hope that you have time for some question if someone in the audience wanted to ask you something.
Oh, absolutely.
Wonderful. Bueno, a todos los que están presentes les ofrezco, ya sea a través de levantar la mano y dirigirse directamente a la doctora Stover si quieren hacer alguna pregunta, o a través del chat las podemos dirigir nosotros también. Doctora Sosa, no sé si tiene alguna pregunta para la doctora Stover.
Gracias, Maria Paz. Yes, Dr. Stover, I do have a question for you. I would very much like your opinion because of everything has been locked down. The horse racetrack have been locked down during about 4 months already here in Chile. So what are we supposed to expect considering the lower level of exercise of our thoroughbreds and perhaps a slight change in diet and a possible decrease in their athlete condition? What are we supposed to expect when racing resumes?
Oh, I think that's a great question. I'm not sure I know exactly what to expect, but I think we have to be very careful to recognize that the horses need to retrain and readapt their bone to racing circumstances. This would be so bone, because it's heavy and it's mineralized, is expensive energetically to carry around. So if the stimulus for maintaining that bone is removed, for example, if the horse is completely laid up, they will lose bone material, just like an astronaut going up into space. So I think there are some challenges. If they've actually had a reduction in exercise intensity, they will have lost bone material, which is normal, but they'll have to retrain the bone so that it successfully adapts again. So we need to be careful. And I think this can be particularly hard because what we find is that horses that get sore because of a stress fracture or for another reason that have been in training and understand the racetrack, when they've been laid up, they come back to the track, they feel really good. They no longer hurt, but they know what to do. And so oftentimes we'll be told for a horse that had a humeral or a scapular fracture, this horse felt really good, just went out. There was no reason we were expecting a problem, and they end up with a catastrophic injury. So I don't, it's hard to say depending on the level of how much the horse was cut back from exercise and training, but I would be careful with them. And it brings up another point I think that is important. Bone trains to the level of exercise that it sees. It adapts to the level that it sees, not so much the amount. So if you trot your horse all the time, it's going to adapt to trotting. But if the bone sees a higher level of intensity during that period of exercise, it will train to that higher level. So one of the things that we recommend even during training of young horses is if you're taking the horse out for a training event, trot, gallop, try to generate some cardiovascular fitness, but only for the last little bit, let the horse extend to racing speed or to a faster speed. It's that last little bit, but for a short distance, that tells the bone, I need to adapt, but does not create so much damage that it gets into trouble. Well, the same thing might apply to, we're no longer exercising as much, but let the horse for short periods of time, see the events that it's going to compete at. Does that make sense? I'm not too sure I got too long-winded there.
No, yes, it does make sense. Yes, because I was, my question was directed in that way exactly because of the layup.
Yeah.
So I do agree that we have to be very careful with the thoroughbreds. Perhaps I'm cautious, I'm concerned that we might experience a larger number of non-recoverable lesions during races when we return.
Yep, yep. I think you're, I would share the same concern. Yep.
Thank you, Doctor.
Thank you, Paula. Thank you, Dr. Stover. I have a question from you that I'm going to read to you from the chat. It's from Dr. Mauro Berna from Argentina. He say thank you to you and congratulate you about the lecture. And he wants to know, what is your opinion about biphosphonate?
Yes, that's a good question. I do not recommend or advocate bisphosphonates at all. Bisphosphonates will inhibit bone remodeling because they reduce the ability of osteoclasts to function, and therefore damage continues to accumulate in bone. And we actually want damage to be repaired. A small amount of damage is actually the stimulus for adaptation of that bone. It's kind of like if you haven't jogged for a while, you go and jog on concrete, your tibia or your shin will be a little bit sore, but your tibia will respond and adapt. So that ability to remodel bone is really important. And so we don't want those cracks to just accumulate and accumulate. Secondly, bisphosphonates actually make bone lose its toughness. So toughness is the ability of bone to inhibit the propagation of cracks, and the propagation of cracks make the catastrophic fracture. So there are two reasons I recommend avoiding bisphosphonates, period. The only application, I shouldn't say only, but if you think about it in human medicine, bisphosphonates are only advocated for people with serious metabolic disease or osteopenia related to aging. They're not recommended in athletes. They're not recommended in youngsters with growing bones. So I think the use of bisphosphonate in racehorses is really a mistake.
Thank you so much, Dr. Stover. I'm going to give you Dr. Carolina Duran the microphone so you can speak directly to Dr. Stover.
Sorry, now I got it.
Okay.
Hello, Dr. Stover.
Hi.
From Valdivia, Chile. Thanks so much. Amazing talk. It's a topic that everyone that works with horses, it's very interested. I was wondering a little bit, following up Paula's question, and considering all the amazing stuff you have been doing in your research, how do you make the connection with the racing industry and change recommendations about which horses can race, how they should train, and which checks you should be doing before the race to avoid these catastrophic injuries? And especially because, I mean, our industry is way smaller and in baby steps in comparison to what's happening in North America. So it would be interesting to what Maria Paz was saying as well, that it's important to make the connection with all the people that are involved to get to the best point for everybody.
That's a really good question. Well, first of all, a couple of things. when we do research studies, we look at large numbers of horses, relatively large number of horses. And it's relatively easy to show an association between risk factors and injury. It's very much harder to look at individual horses and predict which one is going to have a problem. We have, I think, initially our biggest shortcoming was communicating things that we find to the industry, and we're doing a much better job of that now. Because the more information the trainers, the grooms, the owners, the jockeys know, the better they're able to help detect when a horse isn't its normal self and behaving appropriately. So we've had about a third to a half in California in the reduction in our rate of injuries. We still have injuries. We're still working hard to try to figure out how an individual horse might be at greatest risk. We've done that, I think, through a lot of small steps, not any large steps. One was recognizing the association with hoof conformation and shoeing and prohibiting large toe grabs. Another was reducing the levels of allowed medication, lengthening the time that a horse has to have after a corticosteroid injection before racing. Reducing, making changes. I'm not sure if you have claiming races in Chile or not, but
No, we don't.
That's a good thing, I think. So we changed those regulations. We're working with exercise history and being on the vet's list for a lameness exam. And so we scrutinize horses more closely that we know have been trained very intensely, but also had a period of lameness that was picked up on the pre-race veterinarian. And when we have a catastrophic injury, we now share the results with the trainer and work to educate the trainer and the veterinarian to educate them. And the more they're aware of the process, the better they're helping. So one, I want to point out to recognize it's much harder to predict an individual horse than it is to look at large numbers and say there are associations. But secondly, we pay attention to their past history, to any problems they've had, limit medication use. We just, you know, we tackle many different areas at once. I hope that helps.
Yeah, thanks so much. Thanks for taking the time and sharing your work with us. It was amazing. Take care.
So, Dr. Jaime Cruces, a friend of us, asks if there is some sort of connection between a pre-existing lesion and the place or the distance in the racetrack for the final failure of the bone. I mean, for example, we tend to see catastrophic injuries of humerus in the curve, metacarpus in the final furlongs, perhaps. Have you seen that?
We haven't looked at that specifically, and I don't really know that we've been able to say that. In reviewing the literature from different places, I think it varies from racetrack to racetrack. Yes, I don't know that I can add anything other than the information you have with the question.
Okay.
Thank you so much. I have another question from Dr. Cristian Garcia from Chile, a colleague member of the board of ACVS, and he wants to ask you, what type of exercise do you recommend in order to get a good bone adaptation in terms of training surface, hard or soft, and intensity for a 2-year-old thoroughbred?
Well, the first part of the answer, I think, was already in the question, which is on different surfaces, we would train horses a little bit differently. I'll start again. Horses will adapt their bones to whatever loads they see, and they're going to see different loads on a very soft surface than they're going to see on a very hard surface. So if you train on one surface but move to a very different surface, you want to give the horse time to adapt because the loads are differently. Going back to the stick analogy, you know, fewer cycles were needed to break the stick with a very large load. And with a very firm, hard surface, the loads the bone sees are larger. So a horse, we would train a horse a little bit less intensely on a hard surface than we would a soft surface until they were well adapted to it. In general, with a young horse, I think that Dr. David Nunemaker's recommendations from Pennsylvania, that were directed toward preventing buck shins or dorsal metacarpal disease, are good recommendations, which are to break the training into smaller, perhaps events twice a week, than have one large training event once a week, and to let the horse trot or gallop or whatever at a comfortable pace. But when you want to increase the exercise intensity, let them do it for a short portion of that training event. For example, you might gallop 1.5 miles, but for the very last furlong, let the horse see speeds or an intensity that it hasn't seen before, so that the bone sees the new level, gets a small amount of damage, but is allowed to adapt to it, as opposed to training at racing speeds for a large distance. So the bone only needs to see a small amount of this new intensity. So it's easy to talk about bone, but I recognize that trainers have to train muscle, cardiovascular system, but for bone, it responds to the level of training, not the amount of training.
Very clear. Thank you, Dr. Stover. And we have another question from Dr. Ignacio Coloma, also from Chile. He wants to ask you, what do you think, or do you think is a good idea, measure and limit the number of races that a horse can run in a month?
I do think we have to be careful about limiting the number of strides of very high load cycles. Limiting the number of races in a month may be helpful in allowing, again, I might start again. So I think trainers are under a lot of pressure to race horses. Unfortunately, here in California at the moment, trainers are under pressure by the racetrack to fill races. If we say, and that ends up with horses being trained and raced too hard. If you limit the number of races per month, it could in fact reduce the number of injuries if the trainers aren't responding by training them harder in the training events between the races. So you have to look at both racing and training, but it's possible that that strategy could be helpful. I feel like I'm putting too many ifs in here, but you know, I think the questions are good. I think that the reason the questions are good is they're hitting key concepts, but the answers are not always as black and white. A lot of horsemanship, listening to horses, seeing how they're doing, plays a big role in managing horses. So, yeah.
Thank you so much. We have some questions from Facebook. Poncho Mendoza congratulate you about the lecture, and he wants to ask you about the physical exam. How often, as a routine, you think that is necessary? A deep clinical exam, as you show in the lecture.
Well, again, I think it depends on the barn, the trainer, the relationship with the veterinarian and the trainer and the horses. So ideally, it varies from country to country, but I think the ideal relationship is where the trainer and the veterinarian have a very good relationship, and the trainer and the veterinarian are whether daily or twice weekly or weekly, talking together, looking at the horses. And if there's any change in temperament, attitude, performance of a particular horse, then I think a more detailed examination is needed. So I think one of the things that we realized is that some horses that have catastrophic injuries never saw a veterinarian. And so if we have a good veterinarian trainer relationship, then when the horse changes its behavior in one way or another, then I think it's worth a good examination.
Thank you so much. And another question from Facebook is about if you know what has been done in New Zealand that shows a low number or a low incidence of catastrophic injuries during what you show us in the lecture.
Yes. I'm sorry, but I wish I did know. I'm not that familiar with what New Zealand is doing. Australia is also doing fairly well. And I wish I knew the answer. Thank you for the question.
Thank you so much. And we have another question from Dr. Raúl Maldonado from Paraguay. He said, you talk about the relationship between patellar intermittent lockups and vertebral injury. Can you explain more how they relate?
I think that we assume that when a horse appears to lock its hind leg in extension behind it, that it's a patellar lockup or patellar fixation. But I'm not sure whether they directly relate or whether we're misinterpreting the sign. So it's possible that the nerves emanating from the vertebral column are either painful or their conduction is interrupted, so that, for example, the quadriceps muscle may be able to unlock the patella. Or it may just be a direct result of inability to use those muscles from a neurologic deficit at that point in time or in pain. So I don't know that whether there's a direct relationship or whether without knowledge that it could be a vertebral problem that we're associating that hind leg extension with a patellar injury or a patellar luxation or a patellar fixation. A little bit unclear. I think the reason I mention it is because we've noted it in horses that ended up with a lumbar vertebral fracture, and we think that the lumbar region should be considered or examined when you have a horse that's presented with similar clinical signs.
Thank you so much, Dr. Stover. I'm going to give the microphone to Dr. Rita Roca from Uruguay.
Hello.
Hello, there? Yes?
Yes.
Hello, doctor, how are you?
I'm good. How are you?
Very well, thank you. Thank you so much for the lecture of the association from Chile. I can imagine from my house to hear this interesting lecture from you. But I want to ask you something that as I was listening to you, as you know, we have a plan here, how we work with the necropsy program. And when we go to the races, we consider a horse in risk when he's more than 3 months out of the races, 3 or 4 months. Mm-hmm. And sometimes we have difficult to put which is the time, 3 months, 3.5, 4. So I want to know if it's really there's a time or a period that we can say, okay, it's very different if the horse was 3 months, 4 months, 5 months out of the training, or after 2 months, it's the same.
Yes. I think, there's not an easy answer. And I think the reason for that is it depends whether when a horse was out of training, was it stall rested? Was it still trotted or ponied? Was it turned out to pasture? I worry about horses that had a severe enough injury that they had to be stall confined because they're at risk for losing more bone. And so ideally, we would pick up a very mild injury early so that the horse could just be trained a little less intensely until repair caught up with the damage and the horse would continue on. In that case, there may be no distinct layup, just a temporary reduction in the intensity of exercise, but still exercise. If a horse had a severe injury, meaning that it was at risk for catastrophic fracture, then it must be stall rested for a period of time. In that case, I think that the minimum period, we have evidence that if they come back before 2 months, they're at high risk for catastrophic fracture. So it takes a longer period of time once they've been completely stall rested. They've probably lost some bone as well as haven't completely healed that injury. But I think the period of time varies with the severity of the injury and consequently the severity of the layup. So if a horse had a layup for 2 to 3 months, I'm going to expect that that horse needs to retrain its bone to adapt to the rigors of racing. So unfortunately for all of us, I think the answer is not that discrete. It depends on what the horse has done in the meantime and what it's been dealing with. But we know the most about humeral fractures, and we do know that if the layup period was less than 2 months, they're going to be at great risk for after layup.
So perhaps it's correct to not only use the time of the layout, if not the why it was there. So 2 variables, the time and the reason.
Yeah, the reason, the time, and what they were doing during the layup as well.
Okay.
Yeah, okay. And so ideally, I think it's, we really don't want to lay up. We want to keep horses in some form of training if possible.
Okay, okay, yeah. Perfect. Thank you so much for the answer.
Yep.
Thank you, Rita. Thank you, Dr. Stover. I have another question from Dr. Ignacio Coloma. Do you think there is a safer track surface, dirt, turf, polytrack, in your experience or of your knowledge?
Yes. In our experience, synthetic surfaces have proven to be safer, not only in California, but nationally. There's good evidence from national data as well. Tim Parkin's data with the Jockey Club, that synthetic surfaces definitely have a lower fatality rate than dirt or turf surfaces. Having said that, at least in the United States, synthetic surfaces have been harder to manage, which I think has been part of their difficulty for keeping them on tracks. And there's a lot of variability in synthetic surfaces and dirt surfaces and turf surfaces, so that you can have a fairly well-managed, safe dirt surface, a fairly poor managed, or I shouldn't even say managed, a poor dirt surface. So there's great variability among them, so that if you have a track that you can manage well, that has some mechanical behaviors that are optimal for the horses, they can be a good track. But overall, both in California and nationally, when you compare all tracks, the synthetic surfaces have definitely been safer to a significant degree.
Thank you so much. Dr. Sosa, you want to keep going?
Yes, Mrs. Constanza Bur asks, well, she thanks for the lecture, and also she would like to ask about the effect of the use of clenbuterol in training and bone density.
Oh, you know, I should know the answer to that, but I don't. I'm not knowledgeable about clenbuterol, so I apologize, but I really don't know.
Okay. And there's one last question about Fernando Rivas, who says that it's quite important to officialize as soon as possible anabolic control. What do you think about that? Anabolic control in thoroughbred horses?
Well, I'm embarrassed to say that I'm not particularly knowledgeable about anabolic steroids. But having said that, I think it's important that they not be used in racing.
Perfect. You do a constant anabolic control in USA, right? I mean, not necessarily during race season.
I'm not sure what you mean by constant control. I think our most effective, our abilities to manage it are when horses are training and racing. Mm-hmm. So I'm not sure what you mean by outside of racing, but yes.
Perfect.
Dr. Stover, I have another question for you about the surfaces. In the period of pre-training, when we are leaving the foals from the farms and then they're going to the training centers, or here in Chile, directly to the racetracks, with a short period of time of preparation before the races, do you think that they need to be in contact with different surfaces, or the new thing that is happening in some farms is the use of rubber in the carousel, in the place where they train before going to the racetrack? What is your opinion about that period of training, pre-training, and the surface that the horse is going to be related with?
Well, I think it's healthy for bone for horses to experience different surfaces during training. It helps them to adapt to more surfaces. But I don't have anything against using rubber in surfaces. But if the characteristics of the rubber surface are different from what they're going to see at the racetrack,
Mm-hmm.
need to recognize that they do need a period to adapt to the new surface. So I'm assuming that the rubber might be used to be gentler on the bones and the limbs of the horse. Maybe that's an incorrect assumption, but if it is, that's okay and maybe beneficial early on. But when these horses make the transition to a firmer track, recognize, or a different track, recognize that they're going to need time to accommodate and adapt to that different racetrack. They're not just immediately ready for it. If I make another analogy, if you're jogging in sand, you're going, and you're not used to it, you will be sore in muscles and or bones until you adapt to jogging in sand. Then if you jog in sand and adapt and then go to jogging on a very hard surface, you're probably going to get a different type of soreness.
Mm-hmm.
And so I think it could be good to help these young horses not have too high loads on their bones early, but they will have to adapt when they go to a different surface. And so you just recognize that just because they are adapted and healthy on one surface, that they're ready for something different. They need time to adjust to that as well. So I don't think it's a bad thing, just recognizing that, what happens, there'll need to be an adjustment. Does that make sense?
Absolutely. Also, I think that too, because if the change is going to be quicker, the period of time is really not too long before going from the farm and start in a racetrack. I think it's important that they have contact with the surface that is going to be there for the rest of their sport life.
Yeah. Mm-hmm.
Thank you so much.
You're welcome.
So I think that we have done with the questions. Paula, do you see any more questions on Facebook?
No, I don't.
So we want to thank you so much for this amazing lecture and for all the time that you have given to us answering all the questions. It has been an excellent talk that I think is important. I am really happy to see some people from the turf present in this lecture. So I want to say thank you again. And los invitamos a todos a continuar con nuestras charlas. Tenemos nuestra última charla de julio, el próximo martes, también a las 18 horas, donde nos acompañará el doctor Jorge Lose y vamos a hablar acerca de lo que está ocurriendo a nivel mundial con los asnos y los burros. Así que creo que también va a ser una excelente charla. So I want to thank, bye-bye, Dr. Stover. Thank you so much. Yep. I hope you can join us again. Hopefully that you are be able to come to Chile in the future.
Oh, I would love that. And I would certainly, if anyone has comments later or observations they think are important, please feel free to reach out to me.
Thank you very much, Dr. Stover. It is an honor and a pleasure.
Amazing, buddy. Congratulations.
Okay, bye-bye.
Bye.
Thank you.
Take care.
Bye-bye.
Buenas noches a todos. Muchas gracias por haber estado presentes en nuestra charla.